Here is a 70-year-old male patient named XYZ who hails from Koims Madikeri. He doesn't work currently, but previously he worked as a daily wage laborer, and he has received no formal education, and he belongs to a socio-economic status of lower middle class according to modified VG Prasad scale, and the history was given by his wife, whose history is reliable.
Okay, now there are 2 points here I just want to highlight. The occupation, it is not enough. It's okay to say that previously daily wage laborer, currently not working, okay, because of the aging. But the complete occupation history means whatever the nature of the work has to be taken precisely. That means provided like he was dealing with your hay dust, what is that, paddy field, hay dust, isn't it? Or somebody in the sugarcane field or dusty environment, old occupation in the mines, coal mines or asbestos, chemical industry, all those things has to be taken very this thing, because we are talking about a respiratory case. So there are so many occupational lung diseases. So in the respiratory case, occupational history is very, very crucial and important. Okay.
Yes, sir.
And your patient is respiratory case and 70 years. You have taken the history from the wife. That means the patient is not able to talk.
Yes, sir. He could not talk properly.
Fine.
And he comes with the chief complaints of breathlessness, exacerbated from 6 days, which was present since 10 years, and cough with expectoration since 3 days.
Okay. Now, again, there is a point to modify here. The chief complaint, the current admission is required. The past 10 years illness is not required for the chief complaint. Yes. Now, I would present it as exacerbation of the breathlessness for the 6 days. That means the moment I prefix the breathlessness with the exacerbation, that means he had previously the breathlessness. The current admission is for the exacerbated breathlessness of 6 days duration and exacerbated cough, if it is aggravation, okay, of 3 days duration. Okay, those 2 symptoms. But 10 years history will not come as a chief complaint. Okay.
Yes. And in the history of presenting illness, the patient complains of breathlessness, which has worsened from 6 days. It was insidious in onset and was initially present on doing moderate, heavy work and progressed to a present stage of breathlessness on performing daily activities. It is present intermittently throughout the day. And the breathlessness aggravates in cold weather and is more in the morning and slightly relieved on bending forwards. It can be scaled according to MMRC to a grade of 4. And he also gives a history of breathlessness since 10 years. Some episodes were tolerable and severe episodes required hospital admission. It is associated with wheeze during episodes of breathlessness.
Okay, Arpitha, you have taken a reliable history, we agree, but you need to re-modify it. Yes. Most of the factors are there or required things are there. You need to reorganize. I will come back to that a little later. Whenever you talk with breathlessness with wheeze or without wheeze should come first. Now your last letter, S of the wheeze, should come here along with this. Patient complains breathlessness with wheeze. Now in the history of presenting illness, you can say that even though he has come for the breathlessness with wheeze of 6 days duration, he has this breathlessness with wheeze for the past 10 years. To begin with, 10 years ago, what was the amount of breathlessness? How did it progress? Initially, several years he was not hospitalized. Only for the past few years or 1 year he has recurrent hospitalized because of recurrent. So those things has to come. Now I will reorganize and put it. I'm just highlighting those 2 mistakes. Elegant. Okay. Again, the grading, he was not in MMRC grade 4. What was the grade? It would have been grade 2. That means sudden exacerbation is there from grade 2, grade 4. So we need to understand what is the precipitating factor also. Why did his stable breathlessness for a month or so after last recovery, he was stable. He was able to do his day-to-day activity. Why did it suddenly worsen? Did it worsen with the fever? Did it worsen with some exposure to dust or some allergens? Such things has to be mentioned. Or with the increased expectoration. Okay. Fine. You have
Cough,
something
which
more, I
is
know
present
that.
since
Yeah.
3 days. It was insidious in onset and gradually progressive. It is associated with scanty amount of sputum, white in color, mucoid consistency. It is neither blood tinged or foul smelling. Cough aggravates in cold weather, and it is more in the morning and no positional variation. Cough during past were relieved over 6 to 7 days with no hospital admission. Present symptoms subsided on admission to hospital and on receiving treatment. At time of examination, patient says that breathlessness has partially subsided and he has no cough now.
Now, do you think that cough is a significant symptom in this patient, or is it associated with breathlessness? There are two things, no? Significant
Yes,
symptom and associated symptom. We
associated.
always talk about associated.
Yes.
So, is it cough significant symptom?
I don't think it's significant.
So, you need to modify that. Okay. Because the patient does not have significant expectoration at all. No, he mentioned some hemoptysis, color of the sputum, everything. Nothing to suggest
Yes.
infective one. Nothing to suggest a large quantity of sputum production. So okay. So then,
Yes.
if it is associated, you can go two symptoms together: breathlessness with wheeze, which was associated with the cough. Whenever he gets breathlessness, he gets cough, probably dry cough or cough with the scanty expectoration. That is more appropriate to present. I will tell you how to present that. And again, cold weather exposure usually manifests with the breathlessness, not with the cough. Now,
Yes.
even if it is cough, it will be dry cough due to the bronchospasm. Okay, if you know the mechanism of cough, cough
Irritation.
is produced because of the irritation to the tracheobronchial nerve endings, the tracheobronchial thing. It's a reflex phenomena. What happens in the cough? Because of the tracheobronchial tree irritation, suddenly it produces diaphragmatic contraction, forceful expulsion of the air through the open glottis to expel whatever the unwanted secretions of foreign body. Yes?
Yes.
Fine. So if that is significant thing, you need to, so even the bronchospasm, there is a stimulation, pulmonary edema, everything can induce cough. So if you need to understand the patient's disease, is it a significant cough, predominant cough, or predominant breathlessness associated with cough? Okay.
Yes.
Fine.
And there is no history of hemoptysis, chest pain, recurrent infections, rhinitis or sinusitis, fever, or TB contact. There's no history of orthopnea, swelling of legs or PND, no sudden loss of weight, dysphagia or hoarseness of voice. There's no history of joint pain, skin rashes, numbness of extremities.
So in this background, I will just like to highlight any elderly patient after 50 years coming with even a known respiratory disease, coming with sudden onset of breathlessness and cough, unable to speak. You have taken that history of orthopnea, PND. It may be a secondary, previously he had respiratory illness. Doesn't mean that he should not develop a new cardiac illness like acute myocardial infarction, pulmonary edema. So chest pain is also should be included. Okay. Now I would like to modify in this way your own history. You can read this.
Patient is known to have episodes of breathlessness.
No. When you present, always in the like to the peer or your examination is always better. Sir, my patient is known to have episodes. You can read.
Sir, my patient is known to have episodes of breathlessness with wheeze for last 10 to 15 years, which
So
was insidious in
that is the thing. So episodes of breathlessness, if you have understood that history, episodes of breathlessness with wheeze for last 10 to 15 years. I do not know exactly what is the duration. I'm just assuming. Okay. From whatever the history you have given me, which was insidious in onset and gradually progressive. It was associated with the cough with scanty viscid sputum. Okay. Arpita, are you there or you have? Hello? Hello? Okay, anyway, we'll continue. The initial few years, his symptoms were mild and initial few years, the symptoms were mild. He was able to perform all his duties. However, he used to have more symptoms of breathlessness and with wheeze and cough during winters and early morning hours or on exposure to dust and pollen. This will be typical history in a case of episodic breathlessness, like in a bronchial asthma. Okay. Hello, am I audible now? Somebody, application? Hello.
Yes, sir. You're audible, sir.
Okay, fine. Arpitha is unmuted or something. Asked to unmute somebody. Arpitha, somebody can unmute her.
Yes, sir.
Okay.
I'm unmuted. Yes. Sir.
Okay, fine. So if your history goes correctly like this, it will definitely favor to a specific disease. Of course, I know that many a time the history may not be exactly the way we want it, but it is our art to elicit the proper history. You should know the natural history of particular disease and elicit the proper history and mention it in a proper way. Then for the last few years, so initial years he had only winters and early morning hours or exposed dust, that is the typical history. Last few years he had aggravation of the symptoms necessitating few hospitalization for the relief. That is what you had given us, isn't it?
Yes, sir.
So I have remodified that. The symptoms gradually progress so that even in between the attacks or episodes of worsening, he could do only less than moderate or less than normal work. During the episodes of worsening, he was quite symptomatic even at rest, preventing him to do his daily living activity or activity of daily living. That means he could not take bath. That is during acute episodes. So this explains your fever, cough, breathlessness, his limitations, his grading, everything in one few sentences. So even though you have taken many proper history, you have to modify that, okay, and make it short and appropriate. Okay. Fine. Currently, he has sudden exacerbation. This is the current history. This is all past 10 years we have come. Currently, he has sudden exacerbation symptoms from the few days, past 5-6 days, present throughout the day. The symptoms, what is present? Cough, breathlessness, wheeze, all those things present throughout the day, limiting his daily activities. Okay. However, there is no history of fever. You have not mentioned about fever. Fever is important. Purulent sputum. Fever and purulent sputum always indicate that the aggravation is because of the secondary respiratory infection. Okay. Or hemoptysis, or orthopnea, PND, chest pain, so on. The current episode has subsided after initiation of treatment in the hospital. Okay, that's what you have given us. And at the time of examination, his symptoms have reduced by so much, markedly subside, he is able to communicate. But you already mentioned to us, you have mentioned in the beginning that informant is a wife. That indicates that his symptom was not totally relieved to 50% or so. He was unable to talk. Even while talking, he had breathlessness. So that you have to modify and put it. Okay. This is to modify your history. Okay. Fine. Now it is your slide.
Coming to the past history, patient has similar complaints of breathlessness since 10 years, for which he has been admitted to hospital for around 6 to 7 times and treated. Previous episodes were comparatively less severe than the present.
I will interrupt here.
Yes.
Now we have, in the history of presenting illness, we have talked about his illness of 10 years of breathlessness, cough, and expectoration, because a long-standing disease. The same thing happens in rheumatic heart disease as well, the long-standing disease. In the past history, you need to talk about all this history of aggravation. So all those things we have explained in the, I have modified that in the presenting illness. Okay. Now you are talking about illness which is beyond 10 years, prior to the 10 years. Okay. Again, there is a link problem. Okay. Okay. So similar episodes were, that's what you said. History of tuberculosis 25 years back, which was completely cured. Are you able to read now?
Yes, sir.
Yes, read.
He gives a history of TB 25 years back, which is completely cured. He's not a known case of hypertension, diabetes, asthma, epilepsy, pneumonia, lower respiratory tract infections, heart diseases, bleeding, or any clotting disorders. There's no history of prior surgery or no known allergies.
Why did you mention that no lower respiratory infections? He had tuberculosis long back, 25 years back. He did not. Even a normal person will have once in a year respiratory infection is quite common. Simple bronchitis, other things are common. We did not mention that no lower respiratory tract infections.
Recurrent.
Recurrent. You need to add recurrent respiratory infection or so-called mucopurulent relapses. That is fever, cough, breathlessness with expectoration, purulent expectoration. Okay. So that is what you are intending to say. Okay, that is very specific in a case of long-standing breathlessness, long-standing cough, so-called chronic airway disease. Okay, so those are things important. Fine.
Past history, history of TB 25 years back, for which he has received complete treatment. He's on inhale.
Previously, we have received, we have told about 25 years back. No, we need not repeat the same thing. Okay.
Yes. Yes.
Yes.
He is on inhalant medication for breathlessness. Particulars are unknown. Recurrent admission to hospital for last few years, and that is for the treatment of his exacerbations. Is not a known case of hypertension, diabetes, asthma, pneumonia.
Okay. These past histories have been included in the modified in the present history because everything in the 10 years we have briefly mentioned that. So in the past history, okay, you go ahead. You need not mention those things. Okay.
Yes. Coming to personal history, he consumes mixed diet and he has decreased appetite and his sleep is disturbed and his bowel and bladder movements are regular. He is a chronic smoker since 50 years and he smokes 20 BDs per day and he is also an alcoholic since 35 years. There is no other history of substance abuse.
Fine. So he's a chronic smoker and alcoholic.
Family history, no similar.
I do not know whether it was told to present this way. I would prefer you to present family history earlier than the personal history.
Yes.
Okay.
Family history, no similar complaints in the family. His sister was diagnosed with diabetes 10 years ago. There's no history of tuberculosis, pneumonia, asthma, heart disease, hypertension in the family.
Fine.
Coming to the summary, here is an elderly male who's a chronic smoker and alcoholic who gives a history of breathlessness since 10 years with acute exacerbation from 6 days. It is more in the morning and has a seasonal variation, hindering his activities with MMRC score of 4. Similar complaints were also present in the past. He also complains of cough, which was scanty, mucoid, and wheeze associated with breathlessness. From history, it points to a lung pathology, which could be obstructive pathology, that is, any acute exacerbation, or any restrictive lung disease like interstitial lung disease.
Dr. Varun, you are online? Okay, fine. Doesn't matter. Now, okay, elderly male, chronic smoker. He also had tuberculosis, no? Long back.
Yes, sir.
So that has to mention in between somewhere. This score is not required. You need to tell. Hello.
Yes, sir.
You need to tell about his limitation.
Yes.
Okay. Now, from the history, of course, we need to tell that respiratory system is involved, lung is involved. Definitely. Why lung is involved? Because of the significant respiratory cardinal symptoms. You've got cough, breathlessness, wheeze, or breathlessness, wheeze, and cough. Isn't it?
Yes.
So, of course, it is a obstructive pathology, obstructive lesion. It's a airway disease. Rather than obstruction, we can call it as an airway obstruction.
Disease.
Why do we say airway obstruction? Because of the significant wheeze.
Yes.
Okay.
Yes.
Fine. It is once you say obstructive airway disease, there are several airway disease. We have
Chronic
bronchial asthma. There are different types of bronchial asthma. We have chronic bronchitis, and we have something called as bronchiectasis. That is also airway disease. We have emphysema. That is typically not airway disease, but a part of COPD. That is a parenchymal disease. Okay. There are so many conditions which can come into this picture. Now, the disease predominantly manifests with the wheeze, breathlessness and wheeze. There should be airway constriction. Either it should be and the duration is quite long. One is bronchial asthma. The second one is chronic bronchitis. But point against chronic bronchitis is, by definition, chronic bronchitis is a irreversible. What is the definition?
Cough for more than 3 months.
Patient should have cough, expectoration
For 3 months.
3 months consecutively. Expectoration. Cough should be good enough to produce expectoration, good enough for more than 3 months, for the consecutive 2 years or 3 years, whatever. Okay. Now, his history does not fit into that, because you have mentioned that his cough is associated or scanty, episodic cough, not everyday cough. He does not produce significant sputum. In chronic bronchitis, cough and expectorations are predominant, more significant than the breathlessness and wheeze. Did you get my point?
Yes.
So asthma, significant problem will be breathlessness with wheeze and minimal or associated cough. So going by that, this history fixes into obstructive airway disease, predominantly suggests bronchial asthma, unlikely to be chronic bronchitis because it's an irreversible disease. Okay, 100% it is unlikely to be interstitial lung disease. Why it's not interstitial lung disease? Interstitial lung disease manifests with the dry cough. Predominantly that manifests with the breathlessness without wheeze. Interstitial lung disease is the between the alveolus is the problem. Alveolus is not allowed to expand. So there is no airway obstruction in interstitial lung disease. So they do not produce wheeze. Now, if you know different kinds of interstitial lung disease, whatever the interstitial lung disease, they are gradually, once they have started, they're gradually progressive. By the time 5-6 years, up to at least now 10 years, they will land up with one or other complications, because when the interstitium is very thickening, you know that interstitium, there are plenty of vessels, they all get obstructed. Pulmonary hypertension will develop, they will land up with the cor-pulmonale quite early. They will develop respiratory failure quite early. Now, in our history, there is nothing to suggest respiratory failure or edema, right heart failure. So, it is unlikely to be 10 years duration of interstitial lung disease. So, in both ways, presence of bronchi or wheeze is against. Expectoration is against. And even after 10 years, not developing complications like pulmonary hypertension, cardiac failure is very, very, very unlikely. Okay. So I would like to put it this way. I would summarize, sir, this elderly male who is a chronic smoker, alcoholic with history of treated pulmonary tuberculosis in the remote past is having chronic breathlessness with wheeze. And I do not know what is the duration of cough. You have given me only 3 days. I assume that it's a chronic cough, which is associated with breathlessness with the scanty expectoration for more than 10 years. So all things I have summarized again. With the repeated hospitalization for acute exacerbation has now come with the exacerbation of 6 day duration. The same thing in a simpler way. Okay. Now, there is no history of fever, orthopnea, chest pain, hemoptysis, blah, blah, blah. I consider having chronic airway, respiratory system disease, chronic airway disease, acute exacerbation. Now, same thing I have said. I consider him to be having predominantly long-standing bronchial asthma, chronic bronchial asthma. Now, there are episodes of bronchial asthma. There are several types of bronchial asthma. You can classify bronchial asthma in different ways. Now, which bronchial asthma starts at 60 years? I do not know. Usually, bronchial asthma, something called as extrinsic asthma or atopic asthma, starts in childhood. So, you should have taken the history of childhood asthma. Sometimes childhood asthma presents in the few years, by 10-15 years, they get resolved. They reappear after 50-60 years. Okay. So, the past history of childhood asthma is important in this case. If it is there, it is 100% is asthma. Okay. Then, is it only episodes? Or is it how many episodes per day? Is it mild, moderate, severe asthma? Or chronic persistent asthma? You divide it, say mild, that is episodic asthma, less than 2 episodes per week, less than 1 awakening per week, or moderate asthma, less than 4 episodes per week, or more than 2 awakening per night time per week. So, if it present every day, waking up the patient every day because of breathlessness and wheezing, that is called as persistent asthma. Okay. So, which type of asthma? By history, we should be able to tell. Those are all the history diagnosis, not by clinical examination. You cannot diagnose those. Those are all history diagnosis. That classification is history-wise. Okay. So, you should take the appropriate history for that. So, the points favoring bronchial asthma in this particular patient is episodicity. You have said something, episodicity, presence of wheeze. You have told about exposure to cold and early morning, it aggravates. Allergy you have showed seasonally. So those are all the points favoring asthmatic episode. But against age of onset at the 65. Now currently he's 75. You had given me history of starting at 65 10 years ago. So that is one so-called oddity. So if you keenly take more history, it would have been there quite early also. That is also possible. Okay, fine. Now, is it chronic bronchitis? Second possible, chronic bronchitis. What are for chronic bronchitis? Only 10 years duration of the respiratory symptom. If you know the current gold classification of COPD, that tells that the expectoration need not be persistent, like in the standard textbook description. Okay. Now, what did we say now? He should have cough good enough to produce expectoration on every day for 3 consecutive months for 2 to 3 consecutive years. That is the earlier definition. Now the definition is little changed. Even if the patient has got respiratory symptom, breathlessness, cough with or without expectoration, everything more than 2 years, more than some duration, it is considered as a chronic bronchitis. Okay, or COPD, not chronic bronchitis, COPD. So in that context, we can consider it may be a chronic bronchitis. Otherwise, our textbook description of chronic bronchitis does not hold good in this patient because patient is not having expectoration. Agreed? Yes. Fine. Now, against our expectoration, no expectoration, age of onset. There another problem is chronic bronchitis, even in a smoker, starts by the 30, 35, 40 years. The age of onset in chronic bronchitis, breathlessness or cough, age of onset is 40, 45 years. Now we have given the history of age of onset is 65. That is against. Chronic bronchitis is not episodic. It is persistent, everyday problem. Now we have given the history of episodicity. Chronic bronchitis does not manifest with significant wheeze. Mild wheeze may be there. Associated. We have here in this patient, significant wheeze is there. So and seasonal variations are not common. Early morning, after getting up, in bronchial asthma, breathlessness and cough, scanty sputum will be there in the middle of the night. Early morning, 3 a.m., 4 a.m. Whereas chronic bronchitis, he sleeps comfortable till morning. Only when he gets up, he gets irritation, he tries to throw out his secretions after getting up. Whereas bronchial asthma wakes up the patient. These are the history points we have to take to differentiate whether it is we are dealing with the chronic asthma or chronic bronchitis. Okay?
Yes.
Fine. Emphysema. There are some point force. Emphysema is also a chronic obstructive lung disease, even though it's not airway. Chronic obstructive lung disease. Age of onset. Emphysema starts after 50, 55 years. Now this patient has started the illness at 60, 65. So it may be emphysema by history because symptom. What else? Significant dyspnea on exertion. We have mentioned that in the history, the breathlessness limits his day-to-day activity of life, activity of daily living, isn't it?
Yes, sir.
But we have said that one thing oddity is there. It is episodic. In emphysema, it is not episodic. Even till the last stage, patient will be quite comfortable at rest. Because at rest, what happens in the emphysema? Alveolus is expand, but it is not able to recoil. It is not able to expel the air out of the alveolus. Because the alveolar septa, the alveolar wall is damaged. Elastin fibers are damaged there. So it is all always hyperinflated. It cannot expel the air out. Airway is perfectly fine. To expel the airway out, it should squeeze like a balloon squeezing. That is not happening. So what happened? Air is trapping. Now whatever the oxygen is going in, carbon dioxide going out, no issue. At rest, that amount of ventilation and oxygenation is good to maintain the patient at rest. Patient will not have any symptoms of breathlessness. Patient will be able to talk, patient will be able to eat, patient will be able to something. But the moment patient walks few yards, that requires more oxygen to the tissues. That extra demand cannot be met by these damaged alveoli. So they develop dyspnea on exertion. The predominant symptom is dyspnea on exertion, dyspnea on exertion. There will be no much wheeze. There is no much wheeze. Did you get my point?
Yes.
Okay. But there is one thing. The chronic bronchitis and emphysema are the two ends of the spectrum of the same disease called as chronic
Obstructive pulmonary disease.
Obstructive lung disease or pulmonary disease, whatever it is. In a chronic bronchitis, disease involvement pathologies in the airway, predominantly medium-sized airways, whereas in the emphysema, the disease is distal to the terminal bronchioles, alveolus predominantly. So they do not produce wheeze. But in a given patient, both emphysema and chronic bronchitis can coexist. In a patient, chronic bronchitis may be more predominant. In some patient, emphysema may be more predominant. Pure forms may be a little rare, but we do see pure forms as well. Okay. So that is possible. So we need to say that it may be a combination of the chronic bronchitis and emphysema. Okay. Then, so those are the for and against. Now, post-tubercular pulmonary fibrosis, because you had given the history of tuberculosis 25 years ago. So it may be sequelae to tuberculosis, but it's very unlikely because it does not have fever, it does not have the fibrosis or collapse, whatever it is, will not produce significant wheeze. Okay, fine. Then interstitial lung disease, I have told you why it is not possible. It is similarly, it behaves similar way to the emphysema. At rest, they are comfortable. On exertion, they develop breathlessness, exertion without wheeze. And if at all cough, scanty cough, they develop desaturation quite early in the course of the disease. They develop pulmonary hypertension quite early in the course of disease. And as I said, because he's elderly, he's a smoker, it doesn't mean that he should not develop a second, because this episode is not without fever, breathlessness. So it may be a cardiac disease also. Okay, fine. So this is how we comment on the summary. Anything else anybody would like to highlight or tell? The chat box, you can all put the chat box completely. I will answer it separately, okay, for everyone. I will capture all these things like we did for the CNS class. We will do the, yes, that will be easy for me. Yes, we'll go ahead.
On general physical examination, here is an elderly male, conscious, cooperative, and well oriented to time, place, and person. He is moderately built and poorly nourished. His vitals, pulse is 1 or 2 beats per minute, regular rhythm, good volume, normal character. There's no delay.
I'll just 1 second. Can we give the DT of malignancy? I will not definitely give DT of malignancy in this patient. Why? Malignancy of lungs will not manifest with the 6 days aggravation. If they present, they will present with the hemoptysis, they present with the weight loss, they present with the constitutional symptoms. So I will not consider malignancy in this patient. Okay. Fine. Anyway, the relevant chat box question, you can all put the questions on chat box. I will answer and update in a day or two. Okay. Fine. Because it is disturbing. Or at the end, if you have time, we can go through again. Fine. General examination, Arpitha.
Yes. The palpable vessel wall, there's no radial or radiofemoral delay. All peripheral pulses are felt. Blood pressure is 130 by 80 mmHg over the right brachial artery in supine position. Respiratory rate 32 breaths per minute. Abdominothoracic type. Rhythm is abnormal breathing pattern, that is pursed lip breathing. He is afebrile at the time of examination.
Okay, now there are some very specific things you need to concentrate in a general examination of a respiratory case like this.
Yes.
You have mentioned about heart rate, pulse rate is 102 per minute, very good. Okay, rhythm is it. Good volume. What do you mean by good volume? Your blood pressure, you need to always compare this good volume to your pulse pressure. Okay. Either you can say normal volume, high volume, low volume. I do not know what is good volume. Okay.
Yes.
So you need to tell whether it is a normal volume, high volume,
low.
We can appreciate, or you can compare with the pulse pressure. Pulse pressure less than 20 is low volume, more than 60 is high volume. It is a dictum. Between that is normal volume. Okay.
Yes.
Fine. In patient of such kind of patient of chronic breathlessness, what do you anticipate the pulse volume will be? Lower side, medium side, higher side?
Higher side.
Why? Okay. High volume pulse is the dictum in a long-standing respiratory failure patient. Okay.
Yes.
That is because of the carbon dioxide retention, something called a carbon dioxide narcosis. They will have high volume pulse. I'll come back to that a little later. Okay. But you need to concentrate on that. Don't forget about that.
Yes.
Now, you have mentioned something like no delay. What do you mean with no delay?
So no radio radial or radio femoral.
That you have separately mentioned there. Again, there are two. Okay, fine. Palpable vessel wall. Is it palpable or not palpable vessel wall?
It was palpable.
Okay. What are the condition? Because elderly people, elderly person, palpable vessel indicates
Age.
arteriosclerosis, thickening of the arterial wall, arteriosclerosis. That means your pulse pressure of this is very unlikely. In a arteriosclerotic patient where he had a palpable vessels, blood pressure of 130 by 80 is little unacceptable. Okay, whatever it is. Then, if it is in young patient, palpable vessels, what does it mean? Vessel wall. It may be a case of vasculitis. Okay, the vessel wall inflamed, maybe even tender vessels. Okay. Now, then you have the another green thing here is rate 32 breaths per minute or cycles per minute, abdominothoracic. So he has got obviously tachypnea.
Okay.
Now, did you mention that whether the patient is comfortable in supine position or sitting posture or the 45-degree posture? The decubitus of the patient has to be mentioned in the beginning. I don't think that the person with the 32 respiratory cycles will be comfortable in supine position. Do you get my point?
Yes.
So, an elderly male patient, conscious, cooperative, orient time, moderate hypertension, and his decubitus is supine. He is comfortable in supine, comfortable only in this sitting posture, comfortable in 45-degree or 3 pillows, whatever it is. Okay? Fine. You mentioned about pursed lip breathing. Where do you get pursed lip breathing?
Chronic obstructive lung disease.
Not all chronic obstructive.
Emphysema.
In a case of predominant chronic bronchitis, you will not get that emphysema. And in all cases of acute asthma, acute severe asthma, they breathe. Acute severe asthma, they get this pursed lip breathing. So I do not know whether this patient has got acute exacerbation of bronchial asthma producing pursed lip breathing or emphysema is producing pursed lip breathing. Okay, whatever it is. Fine. You have not mentioned JVP appears not to be raised. But you may know that all patients in a chronic lung disease, 10 years duration, 15 years duration, they tend to develop pulmonary hypertension, pulmonary vascular remodeling, and pulmonary hypertension. They all will have the elevated JVP, at least A wave predominancy. If JVP is not elevated, you have to put a hand in the upper abdomen, upper quadrant abdomen, right upper quadrant abdomen, and look for the hepatojugular reflex. If that is positive, it is more likely to be chronic obstructive pulmonary disease. In asthma, contrary, in asthma, in a 10 years duration, remodeling does not occur. Pulmonary hypertension does not occur, and he will not develop cardiac failure. Did you get my point?
Yes.
Very crucial point to differentiate your chronic asthma, chronic COPD. Okay, fine.
He weighs around 55 kg and his height is around 172 centimeters. He has his BMI is 18.6 kg per meter square. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. The patient is using his accessory muscles of respiration and he has flared alien nasi and he presents with pursed lip breathing.
Now I want everyone to be very, very, very vigilant on examination of the clubbing. If it is a significant chronic bronchitis of 10 years duration, they will have clubbing. Okay? Emphysema patient usually do not develop clubbing because they will have good oxygenation rather. Okay? Whereas cyanosis, even chronic bronchitis patient will develop early cyanosis. Whereas emphysema patient will not develop
cyanosis.
Somebody is asking, can you repeat JVP in asthma? What I want to say is that if you know the natural history of the chronic bronchitis and asthma is a episodic disease much milder disease, which is episodic disease, whereas chronic airway disease, chronic lung disease, chronic airway pulmonary obstructive lung disease is a chronic, progressive, irreversible disease. In the 10 years load, asthma will give the respiratory obstruction. If it gives quantum of 10, COPD will give quantum of 80. Okay, the quantum of obstruction to the lung, impedance to the lungs is quite high. So what happens is that the pulmonary vascular remodeling happens because of the chronic hypoxemia. Okay, remodeling. Once the pulmonary vascular remodeling happens, that will produce pulmonary hypertension. When the pulmonary hypertension is there, right ventricular enlarges or hypertrophies and finally fails. So what I mean to say that 10 years of COPD will naturally, not 100%, but at least 60 to 70% of time will have elevated JVP or at least positive hepatojugular reflex. Whereas 10, 15, 20 years of asthma will not have elevated right ventricular failure, features of right ventricular failure. That's what I want to mention that. Okay. Yes, we'll go.
No external markers of TB, and there no
External markers of TB.
Sir, erythema nodosum, tinea versicolor, scrophaloderma,
Do you anticipate such conditions in this patient of the TB of 25 years ago? That is important. I do agree that is important if you're talking about a fever, a patient of 2 weeks history of fever, 2 months history of fever, cough, hemoptysis, to know that whether it is that respiratory infection, tuberculosis. Okay, scrophaloderma can only tell you the old or current running disease. Okay, so that is relevant, but may not be relevant in this particular case. That's what I want to highlight. Okay.
External markers of cor pulmonare are absent, like elevated JVP, ascites, pedal edema.
Okay. So what else? What else would you like to look for? The moment you say carpal nail, that means patient has gone to the cardiac failure. At the same time, you need to look for whether the patient has gone to the respiratory failure as well. Whether pulmonary erythema. Why? In emphysema, it is not a case of chronic bronchitis, predominant it's if it is emphysema, over 10 years, what will they develop? Because chronic hypoxia, they will develop stimulation from the kidney, polycythemia, so they will pink. That is why with the combination of the pulmonary erythema, pinkiness, and no pallor, what is that? What do you call that? Polycythemia, and they partially breathing. They call it pink puffers. Whereas chronic bronchitis, they develop early pulmonary hypertension, early cardiac failure, they develop early cyanosis, and they develop edema, they call as blue bloaters. Okay, fine. And respiratory failure may produce some altered sense of somnolence sometimes, flapping tremor, high volume bounding pulse. Okay, so those are the symptom things you need to take. Yes, go ahead.
On examination of the respiratory system, on examining the upper respiratory tract, oral cavity, nasal cavity, and pharynx appear normal. And on examination of the lower respiratory tract, on inspection, there is no tracheal deviation. Apex beat, it is not visible on inspection. Chest is bilaterally symmetrical, and it appears to be barrel shaped, that is anterior posterior diameter is increased. There is hollowness in the supraclavicular fossa, and intercostal spaces are increased, and there is no intercostal indrawing. Accessory muscles of respiration are used. There's no dilated veins, pulsations, scars, or sinuses. There's no spinal deformity or drooping of shoulders.
Okay, I think respiratory system we have discussed last time. However, you have mentioned barrel shaped chest, that is apparent barrel shaped chest. Whenever you have the anteroposterior and transverse diameters are equal, they call it barrel shaped chest. Very typical in emphysema. Okay, fine. Hollowness in the supraclavicular fossa is also very typical. And at the same time, the sternum will come anteriorly, making appearing that trachea is descending quite deep. No, the distance between the suprasternal notch and the cricoid cartilage will become reduced. Okay. No dilated veins, no spine. Now, usually with emphysema, they will develop kyphosis. Okay. It may not be gibbous. Increased forward bending is very common in the all emphysema or in chronic bronchitis patients, COPD patients. Okay.
Yes.
Fine.
Movements, all areas appear to move equally with respiration, but the intensity of movements in anterior, lateral, and posterior aspect appear to be decreased on both sides.
So bilaterally, marked diminution in the respiratory chest wall movement in all areas.
Yes.
You can, instead of the entire thing, you can simply make it one sentence. Bilaterally, chest wall
Decrease.
movement appears markedly diminished and symmetrical in all areas. Okay.
Yes. And on palpation, all inspection findings are confirmed. There is no tracheal deviation. Apex beat is
It's a bilateral disease. Okay. Fine.
Apex beat is felt in the left fifth intercostal space, medial to the midclavicular line.
That is one which is very, very, very odd. Apex beat, emphysema. If you're talking about emphysema, barrel shaped chest, I do not anticipate you to palpate a typical impulse. I did not palpate the patient. That is a common thing. That's what my experience says. That is oddity. Okay.
There is no tenderness over the chest wall. Measurements, anterior posterior diameter is 30 centimeter and transverse diameter is 32 centimeter. And the ratio of AP to transverse diameter is 0.93. Chest circumference on expiration is 98 centimeters and on deep inspiration is 101 centimeter, and the chest expansion is around 3 centimeters. On measuring hemithorax, right it is 48 centimeters and 1 centimeter on expansion, and left is 47 centimeters and it expands at around 1 centimeter.
How about at what level did you examine this? At what level?
The level of
Sorry?
fourth intercostal space, or on the level of nipple.
Now, how did you examine for the transverse diameter and AP diameter?
Sir, we keep two scales around the lateral aspect and measure the
What scales are those?
uh,
Which scale did you use?
normal ruler.
I know that normal scales will measure only 30 centimeters. Now your measurements are 32 centimeters, which cannot happen with a normal scale. That's why I'm asking. Normally, if you use a normal scale, what happens? You tend to incline it. Either you use two books and measure with the tape, or you use the Taylor scale. You know the Taylor. If you've gone to the tailors, they will have a curved scale. One end is curved, another is straight. You can use that scale. Okay.
Yes.
I've seen it's a mandatory thing in Kerala. All medical colleges in Kerala, they insist to use the Taylor scale. This is what I have seen. They never allow the student to examine with the books and the tape. They insist on the using large scale, Taylor scale on the two sides and another Taylor's measurement between that. Okay.
Yes. All movements appear to be decreased bilaterally, and all the areas move equally with respiration.
Sorry.
So, on movements, all areas appear to move equally with respiration, but the movements in all the areas are markedly diminished.
Markedly diminished. Okay, fine.
And tactile vocal fremitus is decreased on both sides in all areas. There is no palpable rales, rhonchi, or rub. And
now you have mentioned that hyperresonant. Okay. Palpable rails, rhonchi, or rub. Okay, fine. All the areas are hyperresonant.
Yes.
Okay, fine. So, what are the causes of hyperresonant?
Sir, hyperinflation of lung as in emphysema, or in collapse of the lung.
It always typically
Pneumothorax.
it indicates that there is more air in the
lung.
It typically occurs in emphysema. It can also occur during the episode of asthma. Okay.
Yes.
Even in the asthma, what happens? Acute severe asthma, air trapping, similar to the, because airways are narrow. It is not because of the alveolus damage, it's because of the airway, small airways, medium-sized airways are constricted. Air cannot go out easily. So even in asthma, they will have hyperresonancy, but not barrel-shaped chest. Barrel-shaped chest is against asthma. Okay. But hyperresonant can occur even in the acute episodes of asthma. Then it can also occur in pneumothorax and large bullae, emphysematous bullae. Cavity, TB cavity typically will not produce hyperresonance because TB cavity is a thick-walled cavity, so it will always be hyporesonant.
Yes. On auscultation, vesicular breath sounds were heard on both sides. With added sounds, the vesicular breath sounds, the intensity of the sounds were diminished in all areas. And added sound, bronchi were heard, mainly in the upper and the middle lobes.
Okay, now, so bronchi were there.
Yes.
Okay, bronchi, presence of bronchi indicate there is a
Airway.
small or medium-sized airway obstruction. Small and medium-sized. That is it a monophonic bronchi, polyphonic? You should be very specific. Polyphonic bronchi, indicating that multiple airways of the different caliber are causing obstruction, making the forceful airflow outflow. Now, one oddity here I cannot connect is that in significant emphysema of 10 years, where the air cannot go out, it will not produce bronchi. Do you get my point?
Yes, sir.
Produce bronchi. The bronchi is typically produced when the air is expelling out of the airways, alveoli. Okay?
Yes.
So, in this patient, we have hyperresonant node, barrel-shaped chest, and bronchi are also heard. I do not know. I have to examine myself. Okay, fine. And in any of the COPD patient, whether it is, I think last class I have discussed what will be type of breath sounds in a asthma and emphysema or COPD patient.
So vesicular breath sounds with prolonged expiration.
You did not mention that prolonged expiration. It is not simple vesicular breath. Vesicular breath sound is a normal thing. In a airway obstruction in a patient with a bronchial asthma or in a patient with wheeze, we always understand that there is prolongation. There is difficulty in the expelling of the air out of the alveolus, chest wall. I mean, from the chest. It takes a longer time to expel. Patient with wheeze, always breath sounds will be expiration will be prolonged. Don't forget about that. The moment you say wheeze is present, his breath sounds will be usually, not 100%, most of the time will be